Thank you very much. I apologize, but unfortunately, I do not speak Spanish. And I understand there's no translation, so I hope it'll pass okay. English is not my native language either. And in the next hour, we'll take a journey in the forest of trauma. Before, I do want to say that I am deeply and honestly honored by the invitation to speak here. I came to Mexico a week ago, about 2 little weeks after the earthquake. I am very impressed about how the city and the people look. But if we're talking clinically, now is about the time to start and realize who is developing a more pathological reaction to the trauma than it was in the previous weeks. Because basically, within 3 to 4 weeks after the event, you can start seeing who's improving and who, unfortunately, is being stuck in that horrific event. So, as I said, we'll take a journey in the forest of trauma. As you know, when we talk about the general term trauma, we have to realize that not everything is the same. We have to consider what type of trauma it was, whether it was man-made or whether it was a natural disaster. I'll mention it in a minute. We have to talk about the biology and the genetics of what we know now of development of PTSD, post-traumatic stress disorder. We have to consider, I'm a child and adolescent psychiatrist, and I focus on children and adolescents. So we have to consider the developmental age of the child that experienced the trauma. A 2-year-old is different from a 12-year-old who's different from an 18. We have to consider the family's strength and weakness. And we have to look at the society and the culture as a whole, as they also play a part in the person's strength and weaknesses to deal with the event. So what types of trauma do we have? First of all, we have natural versus man-made. Basically, our psyche is dealing better with natural disasters, and man-made trauma have a much more severe effect on us. The worst is abuse and neglect. Physical illness has the same effects as trauma. Accidents and terror is somewhere between abuse and accidents. So from the beginning of times, men always encountered natural disaster, the big floods as they appear in the Bible. But in every country, there's a story about the natural disasters in their history. Again, I'll mention it again. That is Mexico, obviously now, but in your history, there were earthquakes before, 20, 30 years ago, hundreds of years ago, and so on and so forth. Man-made trauma, mostly wars. This is a drawing from the Civil War. And worst of all, as I said, is abuse. Sexual abuse and physical abuse of children. Basically, nobody fully psychologically can recover from them. One of our patients was 6 years old when her father died as a soldier in a war. She was doing okay and she had no symptoms. When she was 13, her mother got remarried and the new man started sexually abusing her. She developed what we can diagnose sometimes as a borderline personality disorder, but now we understand that actually it is not exactly borderline personality disorder, it's more complex trauma disorder. It's someone that has a personality change due to the fact that they experience very severe trauma. And in a way, borderline is almost a condescending term, where post-traumatic is a more appreciating, sensitive, giving hope term. Another example is an trauma of illness. This is a boy who suffered from leukemia. He was 9 years old when he worked in the sanctuary, and you can see in the center, I don't have a pointer, but in the center there's a boy in bed, and all the medical staff are around him, and all their bags are full with tools to treat him. And outside in the playground, there's a little empty space. On the seesaw, hopefully being empty and waiting for him. So children encounter different traumas, natural disaster, as we talked, and man-made. Man-made are exposure to direct violence, abuse and neglect, war and terror. But in both of them, there's exposure to influence. And I think you experienced quite a lot of it in Mexico. The media, now, what part did it play in actually exacerbating the fear after the earthquake? So the media played a part. You have the internet. Computer games are not relevant now, but you have the internet. And actually, even though I recommend strongly that the mental health professionals will work with the media and help them understand the damage of gruesome exposure of scenes of any kind of disaster or trauma event. On the other hand, the internet, basically, I think we realize that there's no way that we can control, and everybody, especially adolescents, get all the information, false or true, into their phones, but we have to take it into account because it does play a part in the way that a person perceives a trauma, especially a child and an adolescent. So I'll now concentrate on what we learned from experiencing and living in a terror-inflicted environment. Now, why is it relevant? Because we were kind of forced to treat children that were victims of terror, but we have learned a lot from it. A lot of it is applicable to other situations. And another thing that is similar, again, I will mention it again, is that both patient and therapist experience the same thing. In the earthquake, both psychologists, psychiatrists, social workers had the same experience as the victims did. It's not something that they experienced and they're coming to you to the clinic and you're feeling safe. You're basically as vulnerable as they are. And these situations, that's why you can learn from one situation to another. So the main points that we learned, that first of all, there's a generational effect. Every culture, every society has previous experiences, and from them you can get stronger or weaker. Your parents can tell you that we experienced a big earthquake and we survived. Or they can say we experienced an earthquake and our life was damaged forever. So there is a certain kind of generational that goes immediately with a second point, which is the damaged container. A central part of any intervention, evaluation, outcome in children are their parents. And if the container, meaning the parents, is damaged, then a non-functional, either because of previous events or because of the present event, the ability of the child to cope and digest and process the trauma is very, very diminished. And finally, a psychological price. Not only individuals pay a price after a mass casualty trauma, the whole society does. And again, I'm a bit like a preacher and I apologize for that, but it really, I feel that it's important to share that knowledge. Now is the time that you as mental health providers can try and convince your government that mental health is important and it does make a difference. Because the more people you help, the better the society will do as a whole. Okay, now these are probably things you're very familiar with. I won't bore you. I will just mention the points. DSM-5 versus DSM-4 had an addition to the main symptom clusters of PTSD. It used to be re-experiencing avoidance and hyperarousal, and they added this negative changes in mood and cognition, which anyways, clinicians, we always saw in our patients. I don't think it's any news that way, but it's important to consider it. We talked about genetics and biology. I will go over that very, very quickly, but just to say that among survivors of life-threatening events, at least, if we're very conservative, 18% will develop chronic PTSD. And that causes significant distress and limitations on their functioning. And why is it important? Because in an earthquake, hundreds of thousands, if not millions, were affected. If you take into account that 18% are at risk of developing PTSD, the numbers are very high. I'm not saying that everybody with PTSD is non-functional. They're different severities, but you have to consider that the numbers of people that need professional relating to is big if you don't deny it. And you can always deny the reality. Many of them suffer from similar symptoms during the first month following the incident. That's what I mentioned as I started. And it's difficult to predict who will develop chronic PTSD. At this point, there's some people that will have symptoms, but it doesn't necessarily mean that they will have PTSD. And I will mention as I go which population is at risk. There is a genetic contribution of around 30% that is found in twin studies, which means that there's some kind of genetic biological play in this situation. It's not just a psychological, spiritual thing. It actually is works on different mechanisms in the body. I'll mention it in again. And PTSD is a real example of the interaction between genetics and the environment. I think one of the most fascinating TED Talks is being given by a pediatrician, and I apologize that I forgot her name, about the outcome of early childhood trauma on the general health of adolescents and adults. There's an increased cardiovascular mortality with people that were victims of trauma and developed PTSD. There's increased mortality from all causes, not just cardiovascular as one stands alone, but the other component is a combination of cancer, lung disease, etc. There's an increase in pro-inflammatory markers, and in a way we think that what kicks into action is the whole immune system that gets out of balance and actually gives wrong signals, and because of that we see all the physiological and maybe the psychological and psychiatric symptoms. I won't go into the details here. I'll mention two things. Children that have been victims of abuse are extremely more susceptible to developing PTSD either as adolescents or as adults from a different incident. If in their background was a domestic trauma, experiencing the earthquake, there's a much greater chance that they will develop a PTSD. We have some articles in this field, but it's not, we don't have now the time to go into that. If we look psychodynamically, doesn't matter from which theory, what is your theoretical background. Oops. I'm not going to go back. I'm just going to say that my theoretical background is Jungian, Carl Gustav Jung, and we actually talk about having archetypes, and one of the strengths of the ego or the consciousness is the hero myth. And in time of trauma, in time of an acute event that's life-threatening, our concept of our own strength, our identification with the hero within us is cracked. We're feeling helpless. We're feeling alone. And psychologically, that theme has to be processed. The fact that instead of being a hero, I was a coward. Whether I was or wasn't, it doesn't really matter. The psychological perception is that I was weak, defenseless, vulnerable, ineffective, helpless. Okay, so just some examples of how these things play out in children. The re-experiencing in children. Most children will have nightmares, but not like adults. It doesn't necessarily have to be the content of the trauma itself. It can be just a general nightmare, and sometimes it doesn't have any content that they can share. They can just wake up crying and say, I had a frightening dream. But it can be a dream about demons, and it can be a dream about aggressive burglars, but it is still, for a child, a post-traumatic dream. In their psyche, there is a contamination between the acute event that they experienced and other frightening images. Same goes with intrusive recollections of the events. With adults, we expect them to have pictures of the event itself. With children, it can be anything, but what we see is that it is repeating itself. It doesn't matter what the image is, but it is intrusive and repetitive. We also see the expression of the flashbacks not necessarily in words, but sometimes in play. And again, the same principle. If the child is very young, it doesn't necessarily will have, and like for instance in this, an earthquake, he can just do 2 cars crashing. But he will do it again and again, every session, week after week after week. And there is a painful reaction to any kind of reminders of the trauma, whether psychological or physiological, and a smell reminder is very common. If a person was at home lunchtime and there were smells of a certain kind of, saying a soup that was on the stove, and the earth was shaking, every time that he'll smell that soup, it'll bring out the memories. And sometimes it's even semi-conscious. They don't even know what brought it on. Sometimes it's very clear. If there's a small earthquake, it's clear that that's a reminder. Or it's a siren. That's an obvious, but there are sometimes more subtle reminders. And sometimes they don't even know to tell you what it was that affected them. And avoidance. Post-traumatic amnesia is actually a kind of an avoidant reaction. We just don't remember it and we shun it out. More known is avoidance of activities, places, and people. They would stop going to their music lessons. They would stop going to an area where it happened. The fear to go back to school where they experienced it would be something to be expected at this situation. And of course, sometimes to be with people in general, or especially people that they were with at the time. And trying to avoid thoughts. Some children don't want to talk about it, and it's important to respect it and not to force it. And some don't want to share their feelings. And with negative changes in mood and cognition, in children we see negative beliefs. They could think it's a punish from God. There's negative emotional state, fear, anger, guilt, or shame. There's diminished interest, as we saw before, in activities, but with a negative mood. They lost interest. It's not like the child that has just avoidance, that has a fear to go to a certain place. They basically have lost the interest in the activity. They don't even want to play music at home. so they're not going to their music lesson. But it's not like another child that has no problem playing music at home, but he doesn't want to go out to the lessons. So you have to be able to differentiate. There's a constriction of play. They become less creative as part of the change in the mood. When somebody is depressed, an adult, a child, they become less playful, less inventive, less communicative. And they have a feeling, even though they're the ones that are detached and estranged, they have a feeling that they don't belong. And, as I said, restricted range of effect, negative effects. Again, emphasis on children. Very, very common is a developmental regression. It's a loss of milestones achieved before the event. Could be motor, language, sphincter control. Most common, you probably know it from your own experience, is going back into bedwetting. That's extremely, extremely common. It could be going back to more regressed eating habits. It could be losing autonomy, being more clingy and more demanding of closeness of usually a parent. But it is very common, and again, 2-3 weeks after the event, it should be expected, and maybe the parents should just be calmed down. But if it insists and stays 4, 5, 6 weeks after, it necessitates a real clinical evaluation and therapy. Right. Anyway, in hyperarousal, I jumped and I don't know how to go back. Like, wow. I'll learn Spanish before the day is over. Nah. Okay, so we'll leave it. Hyperarousal in children is a difficulty to fall asleep and a difficulty to stay asleep. But it also can express itself in difficulty in concentration. And then you see a decrease in their academic achievements, because anything around them attracts their attention because of the hyperarousal, and they can't do their work not in class and not at home. So sleep and lack of concentration would be the major two things. So other expression of hyperarousal, this is mainly in adolescence, and this you should be aware of, is risk-taking behavior. It's counterphobic. Something happened that I was scared, and now nothing at all scares me. I drive like a madman. I have sex without any kind of protection. I smoke pot. Some of them run away from home and get involved with the law, with the legal system. It is a counterphobic mechanism. We talked about before about the psychological aspects, about losing touch with a hero archetype within you, feeling scared. So now you're proving to yourself that nothing at all frightens you. But obviously, you're in a great danger. And you can see new aggressive behavior, arguing and fighting with others. You can see new separation anxiety. New phobia can arise, and the phobia can be unspecific. Again, like I said, the dreams, and I talked about the play. In children, it doesn't have to be specific. From the dark and from being alone. So after the trauma, what might we see? We might see, first of all, the PTSD that we talked about mostly, and I'll come back to it in most of my talk. Because as you remember, we're walking in the forest of PTSD, but you also can see depression, exacerbation of previous psychopathology. If a child had behavioral problems before, they might get worse. If a child had attention deficit disorder before, it was fairly balanced, it might get worse, etc. Eating disorders can start after a trauma. Anxiety disorder, separation anxiety, and specific phobias, as we said, and disruptive behavior. They can all be part of the PTSD, but they also can stand alone. I mean, we all work with manuals. There's a thing that we work with manuals because we have to give a diagnosis when we see a patient. I'm sure it's the same in Mexico, no? But also when we see a patient, after we gave the diagnosis, we treat him. So sometimes they don't have all the symptoms to go into PTSD. But depression, eating disorder, anxiety, disruptive behavior can all be caused or be triggered by the trauma and should be respected as some kind of post-traumatic reaction. And of course, somatic complaint, headache and stomach ache, extremely, extremely prevalent in young children. They would say that they can't go to school because their stomach hurts. And the general mistake is to say it doesn't hurt you, it's in your mind. And it certainly hurts them. I agree. The source of the pain is in the mind. But the place of the pain is the stomach. And by the way, validation is extremely important for all the victims of trauma. Maybe the first stage. Yes, you experienced something horrible, and yes, you are symptomatic, and yes, we can help you. So that kind of validation and giving some containment and hope is extremely therapeutic. Now, be patient with me because there's some slides that we're just talking about in this with you because of being colleagues. But this is a lesson that we learned is extremely important about the effects of the culture and the society on adolescents. I won't go into the whole thing, but I'll just explain that back in 2000, there were two things happening in Israel. One was a wave of terror events, and another was, on the other hand, within the Palestinian territory, the experience of the army and police invading them. The army and police was trying to find terrorists, but the experience of the population is that they are invading their territories. So this is Professor Solomon. She's one of the leaders in the world on post-trauma. The two waves of investment in research and development of therapies to post-trauma. One is post-Vietnam War. There were large numbers of post-traumatic soldiers that came back to the United States. They put immense pressure on the government to recognize and treat psychiatric symptoms that were caused by the war. So it became a central diagnosis in the DSM, and people started researching it and treating it. The other wave, probably all of you are aware, was September 11, when civilians were hurt in New York and all over the world. People realized that you can be affected by trauma even if you're not sitting there. Even if you're just at home, 2,000 miles away, you can be affected by the trauma. And the psychological effects of the trauma are debilitating for a long time after. And the second lesson from September 11, and that is very relevant to Mexico now, is that the helpers themselves are deeply affected and damaged by being exposed and treating the victims. So, anyways, Zahava Solomon is one of the main researchers in Israel, but known worldwide. And what she did is she gave self-questionnaires to boys aged 14 to write their own symptomatology of PTSD. But she also asked them to say how many events of trauma were they exposed to in the last year. We'll just go to the top and the bottom line. Ramallah and Bethlehem are Palestinian youth boys that experienced army invading into their township. They experienced 10 events on the average each. It's not something somebody told them about. It's something that happened that they were present. In the bottom, Katif, it's an area in Israel in the south. Again, 14-year-old boys. They experienced 11.6 events of terror that they were either sitting in the bus or standing in the street when the bomb exploded, etc. Now, the Palestinian youth self-reported 70% of PTSD. The Israeli youth reported 28%. it's misleading, because you may think that the Israeli youth is doing better, but they weren't. The Palestinian culture was encouraging the boys to feel their fear, because they feel that that way they will mobilize and get some help. On the other hand, the Israeli society demanded of those 14-year-olds to be heroes and not complain about their fear. And what is important that when we followed up that group, they developed a lot of school problems, a lot of drug addictions. So you have to know that self-report is not reliable enough in adolescents, and you have to consider what message are they getting from their parents and from the society around them. I'm not saying you shouldn't pay attention to it, but just take it, in Hebrew we say, with a grain of salt. Like, listen to what they're saying, but understand in what kind of environment they're talking. Okay, we'll talk about our experience, the studied experience. I mean, by now, we started in the first 4 years with over 50 events, 270-something minors. By now, we've seen, unfortunately, close to 900, ages 1 month to 18. But what I want to say is this. The ones that we have seen were all in emergency rooms. I have no idea how it is in Mexico. In Israel, in all general hospitals, you have psychiatric department. And in all general hospitals, you have a much smaller child psychiatry team. But you do have in the ER available personnel to deal with the mental ramifications of a trauma. And when a mass casualty event happens, it could be a bus turning over with 30-something people being killed. It could be a bomb exploding. It could be anything. It could be fires. People get evacuated to the emergency room, and there is a routine. All the doctors are being called, of course, from home to help, but also the mental health professionals, psychiatrists, psychologists, and social workers are called. We made sure that we see each and every child personally, sometimes very short, 5 to 10 minutes. Sometimes we had to do actual therapeutic intervention that could take several hours. But what was important, that from the ones evacuated to the ER, you can see that basically 70% did not have any physical injury. Only under 30% had some physical injury. Physical injury doesn't necessarily mean that they were in a critical physical state. Even a broken leg is a physical injury. But usually when you do drills for earthquakes, for war, you always think about what is the hospital going to do with all the physical casualty. There's very little invested in drilling the psychiatric and mental staff how to deal with big numbers of victims. They are the bigger numbers that are being evacuated to the ERs. Okay, so again here, I won't go into the detail, but what is important, that over 80% of the children did not show any symptoms that were alarming. They were a little anxious, but they were fully oriented. They were very clear in the way they could describe what happened, even if they were very young. When you evaluate, are there any child psychiatrists here? Good. Hi. Now I feel at home. In very young children, obviously you take into account their developmental stage, and you don't expect from a 2-year-old to be able to describe an event. But after being 3 or 4 years old and having some verbal abilities to express themselves, and given, we'll talk about it, a decent environment, you can evaluate whether they are capable to describe what happened to them in their own words. But obviously, school-age children and adolescents can describe it. Anyway, only under 20% were symptomatic. Most of them had severe anxiety that some of them showed with conversive symptoms, aphonia, inability to speak, and some with weakness. They couldn't stand on their feet. Two girls couldn't move their hand after they had a very minor procedure of blood being drawn out. After that, they couldn't, as if their hand got paralyzed from that needle puncture. But it was obviously a diverted conversive reaction. You see dissociation, and psychotic we saw very little, and especially we saw after abuse of drugs. It could be an adolescent that was smoking marijuana before, and then the event happened, and then it exacerbated, and she became psychotic. But, I know the literature is different, but we published this, but we have, as I said, by now over 800, close to 900 victims. We did not find any correlation with age and gender. Usually they say girls are more symptomatic. We didn't see that, and we didn't see that either with younger people. So these are the three goals of our acute intervention in the emergency room, and that is what we would recommend that people would adopt. Stabilization and basic needs in the ER surrounding. From the first encounters, support natural recovery process and remove impinging factors, which means if the TV is showing scenes from the earthquake, please close the TV in the waiting room, because it actually contributes to aggravating the experience. From the first time that we see a person, we actively tell them, you experience something very frightening, you're very shaken, it might take time, but you will improve gradually. It's almost the first sentence that we say, and we will keep saying it all the time. First of all, because it's true, and second, because it gives a sense of hope and guidance in that very difficult moment. And this, because we can't treat everybody, I mean, we can't, I don't think you can, I don't think anywhere where one talks about a public system we can treat everybody. It's important to detect the patients at high risk for chronic post-traumatic disorder. And those are usually, I think I have a slide about it, but I'll see in a minute. Those are children that had previous psychopathology, children that were abused before, children that someone of their family or close relatives have been killed, children that their family is not functioning, etc. But I'll talk about it after. It's important to stabilize them in the emergency room, keep them away from ongoing stress. We mentioned most of that. Basic needs, television, and physical pain. If a child has physical pain in their mind, it's a sign of the severity of their situation. A child could have a broken leg that we know that will be mended with a cast, and in about 6 weeks he'll do better. But at the time he's sitting outside and waiting for therapy, for him, it just is a proof that he is in a life-threatening situation. And it doesn't matter what you say, as long as he's hurting, in his mind, it's connected to the severity of the situation. So it's important with the physicians to be very light or very open with giving painkillers. We have a totally different approach when we're talking about psychoactive psychopharmacology. We do not give medication usually. But painkillers, if relevant, yes. We have to explain the medical procedures because to diminish unpredictability, the event was enough. So at this point, we want to say at the ER in advance, you're going to have to wait now for 2 hours because there are many other children that I have to see before you. I'll see you in about 2 hours. If you can't see them in 2 hours, go back and say, I'm sorry, 2 hours have passed. I'll see you in It's important not to give them a sense that everything is out of control. Sometimes happens with my presentation. So why do I press the importance of immediate psychiatric evaluation and intervention? One, it's a starting point for understanding the resolution of trauma. It is a developmental tool for early detections of minor at risks only if we evaluate them immediately. We can detect the ones at risk. It's a baseline for evaluating the children after. You can always reflect on how it was on day one. And by looking into that, each of us can develop and contribute to the immediate ways of intervention. There's no one way that is proven to be better than others. So the more experience one gains all over the world about the effects of immediate intervention with different kind of tools, it will contribute to everybody. What happened to our kids? July 2002, we called each and every child. We talked to their parents. 83% cooperated. 51 were symptomatic. We're talking about a year and a half after the event. Only a very small number came to therapy because of the avoidance of post-traumatic stress disorder and because of the parents' tendency to deny that their child has a psychiatric problem. People don't go to therapy. So with post-trauma, you have to actually help your patients to get the help that they need. You can't rely on them coming to you. You can see a gradual decrease a year after. We talked to the parents and we gave a scale as well. And in 2004, which is 4 years, almost 4 years, 3.5 years after the event, 32% remained symptomatic. So there was a natural recovery, but not enough. And that is why we know that terror trauma, if I would say that in child abuse, almost 80% develop PTSD or complex PTSD. In terror trauma, around 30% develop PTSD. And in general trauma, we mentioned before, it's around 18%. So natural disaster is something around 15%. Somehow we are capable to deal with it better than with other traumas. Okay, so what correlation did it have? Children that had symptoms in the ER were most likely to develop PTSD. Children that had positive PTSD in the first phone call, a year and a half after, remained so, most of them. Whether they were hospitalized, it increased the risk of PTSD. Time from the event, of course, decreased the rate of PTSD. And the level of perceived threat affected it. A positive, negative, protective effect had treatment. If the children received some kind of treatment, even at school, 2 weeks after the event, the counselor talked to them 3 times, they had a better chance to recover. So in a way, the idea is not that each and every child should be treated by a psychiatrist. But teachers, social workers, psychologists that work in the community should have the basic tools to give the basic intervention after a traumatic event, and then only in cases that are more complex to refer them to psychiatrists. Again, no correlation with age and gender. So the follow-up conclusion was alarming rate of PTSD, importance of immediate intervention, and the value of follow-up and reaching out programs because the patients don't come enough to you. Now, this is very important. I'm not going to go through it because it'll take a long, long time. We'll go over the slides, and I'll leave the slides here so you can see them. What we developed from our experience is we developed a form that is sitting in the nurse's station in the emergency room. And if an event happens, automatically we see each child and we fill the form because there's no way that we can keep, at least, we are not superhumans, I don't know about that. Can't remember everything in stress and when we have to work quickly. So when we have a form that we just have to do check, it takes us much quicker and more effective. And so it's being filled by a psychiatrist. We put the full details of a minor, which takes a minute because we have usually a computerized We have it, so we usually put that on the form. It even takes less time to do that. And we write the physical finding. That's important to us, to us. Heart rate, and because we know that the body in a stress situation increases the heart rate and blood pressure. So that signifies to us the emotional situation of the child, and we want him, upon release, to have a normal heart rate. So we do put it there. And we mention what's the physical injury. I'm just that, so broadcast so people can see it, but I'm not going. What was the personal exposure to the traumatic event? What was the proximity? How long? I just give you one example. I'm very aware of the time, so I'm trying now to rush. For me, it's an example from terror. Again, from you, I'm sure you have the same event that you can describe here. It's a very long bus, and the people all over the bus. Families are going in, and the terrorist went on the bus from the where the driver is sitting, from the front, and exploded there, and seat number 2. At the back was sitting a mother with 2 boys, about 9 and 11 years old. She knew what happened. The doors of the bus opened. She took her boys immediately down, crossed the road, went into a house, banged on the door, asked if she could come in. They said, of course you can. She sat in the living room with her boys for 3 hours till the whole scene was evacuated. All the Red Cross, all the firearms, everybody was out. Then she went out with the boys and went home. Later, she came to the emergency room. Could we evaluate the situation of the boys? In actual fact, the boys saw nothing. They heard the noise, but they didn't see anything. In another part of the bus sat a mother with 2 girls. It is true. They were a bit older. They went down, but she didn't move. She sat on the sidewalk next to the bus, and they were sitting there as they were taking off the bus, all the injured and all the corpse. And since you don't evacuate the ones that are slightly wounded first, only last, so they were the last to be evacuated from the scene. So when they came, the 2 families exactly at the same event, but different proximity and different length of exposure and different actual sites. So again, it's important to educate population about it, because hopefully earthquakes will not happen now for many, many years, but other traumas will. And you have to try and minimize the length of exposure and the actual sites. The proximity you can't affect. Either you're close or not close, but you can affect the others. Special circumstances, if a family or friend were hurt in the event, if there was any uncertainty. Sometimes everybody was fine, but a 9-year-old was alone in the emergency room, and it took 10 hours to find out the rest of this family. You can imagine what went on. Personal or unusual circumstances, guilt, etc. If it could be even a car accident, if there was the father didn't want to drive the boy to school and the boy put pressure on him, the father took the car and there was an accident, the boy will feel guilty. So you have to take into account evaluation of the immediate reaction, and we have a whole checklist. Is there dysphoria or tension? Is there crying? As I said, is there any kind of tremor or palpitation? Extreme expression of feelings, disturbed concentration, aggravation, somatization, indifference, self-absorbance, regressive behavior, or no apparent response, amnesia to the event, or dissociation, peri-trauma or post-trauma. So as I said, this is all in the form. You don't have to remember it. You just do check, 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 or no. What's the mental status? If there's any additional findings to what we said before, did we need to do any kind of intervention? That is extremely important. What was the pre-event functioning? That determines whether they're at risk or not. Family, social, academic. any kind of previous diagnosed psychopathology, attention deficit, learning disability, conduct, anxiety, depression, etc. Any kind of post-trauma in the family before that, not necessarily to him. What kind of support system does the child have? Is there a parental conflict, economic problems, parental anxiety, etc., etc.? You can see that. You ask them for permission to contact them by phone because, as I said, most of them will not come to therapy. You have to do a reach-out program. You give, in the emergency, very short guidance. It will be normal that your child will not be able to fall asleep. Or maybe he won't wake up because some kids oversleep. It is normal that he'll be afraid to go to school. But with understanding the symptomatology is also giving the expectation that things will get better gradually. So we give handouts, I'll show you in a minute, and special recommendation upon release. And if the child remained hospital, we specify it. And we mention, as I said, the heart rate upon release. These are the handouts that we give to children with a little help of my friends. You pass something difficult, we are ready to help you with our phone number. This is for adolescent. Nothing prepared you to that experience. You're here, etc. And for the parents, together. This is emphasizing the important role of the parent, that already in the handout, we give him something that together will give him a hand. Your child doesn't always know to ask for help. You're there for him, so are we. So I just want to jump because this is a quote that's important. Exposure to frightening trauma-related stories shared by peers or observing peers with extreme emotional distress may increase children's physiological arousal and alter their cognitive understanding of the experience. That it was more terrifying than what they first realized, and thus will contribute to the worsening of symptoms. So you have to be careful. If because of big numbers, you work with groups, make sure that if someone is being over-elaborate and over-descriptive, you have to stop it, because others that did not have the same experience might be negatively affected by it. Okay, so a few words about responding to disaster. This was Sri Lanka. That was the tsunami. The effect was horrific there, but much like the earthquake, I mean, obviously it's a natural disaster, but buildings were destroyed. Not only, I mean, when we were there, it was a few days after, but the water wasn't there anymore, but just the rubble. But this is the cultural background. When I was there, I learned that in Sri Lanka, in their culture, they relate to a tsunami that happened 2,000 years ago. The divas of the sea had become very angry because the king had killed an innocent holy priest. A dreadful storm came on quite suddenly, and huge waves rolled on the shore, and the land was swallowed by them. The people of the villages had to run for their lives, losing their huts and property. So every culture has disasters in their religion, history, or personal experience. Especially in Sri Lanka, what we hooked onto, that from this big disaster, there emerged in their own myth a new, healthier Sri Lanka with a better, more sensitive king. So in a way, in that horrible story, there's also a direction or an encouragement that one can arise from a trauma. In time of war, it's unfortunately we don't have only terror, we have war, and sometimes when townships are being bombarded, they're totally empty. Anybody who has the financial means leaves and goes to relatives or elsewhere. And even physicians and community workers leave, and only the very poor stay in shelters, exactly. So we went there daily to see them in the shelters. This is a pediatrician, as you can see. This is a medical clown, because we realize that they help us in our examination. Because if they come with us, and we're in a shelter, and there are many kids, first of all, we can see which kid is willing to get involved in the game. Does he have enough emotional ability to relate to other themes than just his anxiety? And also, when we evaluated the mother, the clown could occupy the boy. And of course, with young children, we encourage them to draw. Drawing, playing with games is very natural to children. And this is the first picture, if you can see, of a happy family. Father, mother, child, house, tree, sun, sky. I think it's probably kids everywhere draw the same. And I asked him, is that really how you feel? He said, no, that's how I feel. So sometimes children, like adults, don't expose everything immediately. But it's important not to ask, don't you feel scared? But to say, is this how you feel, or do you feel different? If he says, that's how I feel, you leave it at that. And we learned, and again, I would encourage you to do, as we worked with a steering committee, that there will be a center that on a regular, everyday mode, it is a center. It could be a library, it could be a place where people come for gymnastics or from dance lessons or something, a community center. But in time of emergency, it goes into an emergency mode. And then the population has a place they can turn into. They can come for help. They don't have to go all the way to the hospital, but they can be in their close environment, and we make sure that there is personnel that is Red Cross, fire department, police, social workers, psychologists, and if we have enough psychiatrists that sit in that area, answer phone, and sometimes goes over to the shelters to see the patients that call them. Another lesson is that we encouraged our government with mild success, if I'm honest, because always when something bad happens, the government is willing to invest, and then when things go back to normal, they find other priorities. But we encourage them to invest in training professional people to deal with acute trauma and to give, yes, because areas of poor, vulnerable population usually don't attract the best professionals. And we did manage. For 2 years, we got government support. It stopped now. We hope we'll be able to renew it. Okay, almost done. We'll talk about therapies. You can see all these therapies that are here. My main point is make sure that you learn as a professional to have a tool of therapies that you can deliver to your patients, and then tailor-make the therapy according to the patient. Don't have a routine that everybody that comes through the door will get the same kind of therapy. Not everybody does better with the same. So debriefing usually for staff, group versus individual, be careful about group. CBT, trauma-focused CBT, and prolonged exposure are well-known and documented interventions for post-trauma. EMDR, I don't know if you know it. It's eye movement, rapid eye movement technique, somatic experiencing. Sometimes psychodynamic, in-depth work with some patients is more relevant. With kids, nonverbal interactions. Invest in family and parents. Very rarely do psychopharmacology, and obviously if the child is not doing good and he's depressed or anxious after 2, 3, 4 months, we will help with medication. We just don't rush into giving medication. And recovery. As I said, most people, 85% at least, after an earthquake will recover. And it's high numbers. You have to relate to your own fears. You have to find ways to get help for yourself. It doesn't necessarily have to be professional. It could be any kinds of help. But you have to realize the fact that you yourself are working with a wound. So, a promise for a better future is strengthening the society and the families so they could help the children. Obviously, prevention. I understand in Mexico it's building better, even though I must say that I'm extremely impressed when I'm seeing those high rises and they didn't fall. I can't even understand that. So, but for us, it's war prevention and prevention exposure through television and things like that. Just protect the children and develop services that are affordable, even to people that don't have insurance or money.